one of the things that happens to the thumb in arthritic patients is what's called a shouldering effect. So the metacarpal starts to fall into the palm, right? The metacarpal starts to fall into the palm and it tends to sit there. Well, it's not just with arthritic patients, it's just a natural occurrence in arthritic patients, but anyone with a thumb issue, they might be sitting, like if you imagine this bone and this bone, right? And they're just sitting a little bit off. So what if you kind of did a little bit distraction and put it back in place? Could he potentially weight bear a little bit better, right? So if you went, you grabbed that whole thumb, pulled it back, pulled it out, so you're getting a little space, a little distraction, and then you'd go into extension. If you didn't do anything and you just went into extension, if he's a little bit off, you go into extension, you're malaligned, right? So if you kind of think about joints in that sense, you want to align him just a little bit, maybe do a distraction, and instead of pulling down, you pull dorsally. Can you see that? Like my thumb is freakishly movable, right? Right? So you can check his other thumb and say how mobile is that thumb? Because if I got hurt, someone would have to know that I'm super mobile and that they might need to pull me out and jack me back, and then worked into extension. Once they got that into extension, then you'd have to do composite extension, because that flexor pollicis longus goes across and pulls everything down too, right? So if you think from the joint level to the muscle level to that, like the intrinsic muscle, and then to the extrinsic muscles that cross that joint, that's pulling it. So then you take everything and you pull it out. So you could start with that like kind of passive stretch, and then what could you do to keep it there? What could you do to work on some extension so that you can get some abduction and extension, right? But not from the IP necessarily, but from here. But if you got some passive stretch and these weren't pulling so much, could he just move better? So if you do some weight bearing, you'd almost have to grab him out and pull him back. So sometimes I'll put my fingers when they weight bear, and you can grade it. So it's weight bearing isn't like, let's get on the floor and do 10 push-ups, but you could do some graded ones, and you could literally just separate your fingers, put it under there, and pull out that first metacarpal and get a little extra stretch right on the ulnar side. All right. So the question also was, in general, pain is a good indicator for certain kinds of injuries, but pain-free is a relative term. It's pain-free is what they can tolerate at that moment in time and what they can tolerate after you're done working with them, like hours later. So sharp pain is usually not good, especially in the wrist. Sharp stabbing pain is usually not good. And but if you had there's good pain, like, oh, I feel so good, or like they feel a pulling pain, then that's okay. And then you're just slowly increasing their ability. And when they're feeling a little uncomfortable, that's okay. Sometimes people use pain, but we have to really make sure, is it pain or are they uncomfortable? And that's some of the biggest difference when you're treating somebody, because a lot of times we always, like if you're a real medical model, or you're in a place where everyone's asking about pain, sometimes you forget that you don't have to use the word pain. You might, and this is a strategy that I use, if they say pain too much, then I describe different pains for them. I'll help them out and say, well, do you feel a sharp pain? Do you feel a stabbing pain? Is it a pulling pain? Is it a good pain? Is it like an achy muscle pain? There are different types of pain, and it's not always the same. Right? But wrist ones are really, really like the sharpness you don't want, and it's very sharp. It's very sharp, and then it eases out to a dull, and you don't necessarily want that, right? So when it comes to that, you have your scaphoid lunate and then your triquetrum. Now there was a question on that. So let me see, what was that question about testing? Because we're right The scaphoid and the lunate have different certain tests, and so does the lunate triquetrum have different tests. And most of the testing in the wrist, they're called shear tests. And what's the other one? Ballottement. Am I saying it correctly? I never know if I'm saying that word correct. Ballottement test. So it's really actually important to know that there's several different ones. And so when it comes to wrist provocative testing, you need to learn which ones do testing which ligaments, because there's a shear test also for the TFCC, right? So if you forget that, you're going to confuse yourself. So it's always think like so to slow your brain down in a way, it's like, what am I testing here? Which ligaments am I testing for? And then you can go into the test. So the shear test takes the takes the lunate. So it holds the lunate down, and it takes the triquetrum joint, this part right here, and it shears it, takes this whole part and shears it against the lunate. So what that does is it goes into, when you hold it, right? So one hand holds the lunate. So if you want to shear something together, you have to hold one and take the other one, and you have to mobilize it, right? So keep that in mind. Hold the lunate, take the other joint, and you have to shear it against each other. So with the shear test, you're moving into ulnar and radial deviation to shear it this way, right? Let's say, for example. And then the ballottement test is it takes the lunate and it holds a triquetrum, and it moves it back and forth. So it is the direction in which the force is applied. But it's essentially doing very similar things, looking for instability. So if you're going into studying for the exam and you're like, oh, these questions and stuff like that, it's really important to know which ligaments you're testing, what instability are you testing for. When you have a patient that has a partial ligament tear, just like even the partial tear between the first metacarpal and the trapezium, if you had a partial tear between the lunate and the triquetrum, usually what happens is, if you think about it, it's very similar to a shoulder joint or any other ligament tear. Ligaments hold bone to bone together, right? So the ligaments don't have blood supply. It requires the nutrients from around its area. And so because it doesn't have blood supply, it cannot heal on its own, right? So when patients ask me, oh, I have a partial tear, if I do therapy, will it heal? So I always say, when you tear a part of that ligament, the therapy that I provide for you and help you with, I don't heal that ligament together. The ligaments have to be kind of like sewn together, right? And the wrist is a little differently. But basically, all I'm doing is, because it's not fully torn, it means that there's a certain amount of support, right? So it depends on how partial, if it's a little tear versus a larger tear. But the work that I do as your therapist, as a certified hand therapist, is I find out where you're developing your tightness, because even if you have a partial tear, what they're doing is they're going to immobilize somebody first. They're going to immobilize them because they want to stiffen them up. The immobilization, especially in a wrist ligament issue, is to immobilize, to stiffen someone up. You are relying on scar tissue to build up and stiffen up the joint between here and here, right? You can stiffen that up. Then after it stiffens up, then you go into movement. Then you go into painless movement. And then you try to get as much painless movement as possible. And then you go into strengthening. And then you go into strengthening with minimum pain to no pain. People who cannot get out of that cycle ends up having surgery, because there's either an instability or there's too much inflammation and scarring inside that lead them into having surgery. Right? Surgery in the wrist, the best way to see any tear to its fullest extent is to scope the wrist. So sometimes there's a lot of inflammation, there's a lot of scarring. It's like you want just enough scarring to scar the ligament together. If you have too much, then it's going to block you, right? If you don't have enough, then you're too loosey-goosey. All right, so partial ligaments or you want a certain amount of immobilization, and then you start moving.
Hey therapy friends, it's Huang here. Thanks again for watching my video. And if you like videos like this that can help you just crush it in the hand therapy world as an occupational therapist, then hit the subscribe button and enjoy the video. Thanks again for watching.